you. Thanks for this invitation. So I think we can go ahead with the talk. The topic given to me is ARNI in heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. A new pathway for national consensus. Actually, there is a heart failure with between reduced and preserved ejection fraction. There is a new term, heart failure with mid-range ejection fraction. So we'll be discussing all these three things. So, what new ARNI has brought and what are the usage and where it is not to be used? We'll be discussing both the things. Heart failure can be deadlier than many cancers. If we see the 5-year death rates, then things which are considered more dreaded, like breast cancer, Hodgkin's, they actually have much lesser mortality than what heart failure is having. So, because people do not consider that much deadlier, that's why they do not stick to the guideline management therapy. Heart failure is a progressive condition with a very high mortality risk. There are times when there are waxing and waning phases, worsening of acute decompensation of heart failure, then stabilization, and ultimately the patient dies. In between, there can be episodes of, if we see the overall chart and general population, then not all people die of progressive heart failure, but then there are people who are dying of sudden cardiac death also, which is again a very underrated phenomena in heart failure deaths, and that also needs to be taken care. Heart failure patients, they are at very high risk of death and hospitalization, and as number of hospitalizations increase, the mortality increases significantly. And if there are 2 episodes of heart failure hospitalization in less than 6 months, then the chances of dying in next 6 months is close to 50%. Indians are different in so many ways. We get diabetes much more often. We get premature coronary artery disease much more often. Similarly, the heart failure with reduced ejection fraction, this is more fulminant in Indian population. If we see the overall global population and Indian population, the mean age is less in India. In hospital mortality is high, and post-discharge mortality is again very high in India. And one of the reason is not staying to the guideline dependent therapy. An important reason apart from other reasons is financial constraints also and lack of education. Heart failure survival rates in inter-CHF study, they were significant. The survival rate for heart failure, they are worse for most cancers, for example, those of the bowel, breast, or prostate cancer. So there are approximately 8 to 10 million population patients of heart failure in India, with a prevalence of approximately 1% of adult population. Heart failure is having a post-admission mortality of 20 to 30%. Medical adherence is very poor, less than 50%. And heart failure is occurring in relatively younger population because CAD is more in younger population in India. Incidence of diabetes and heart failure is close to 60% as compared to 30% in rest of the world. And incidence of hypertension is approximately 42%. The 5-year mortality and readmission rates in the patients of heart failure in India, 3 out of 5 patients, they have died during 5 years of follow-up, with a median survival of approximately 3 years in this young cohort of heart failure patients in Trivandrum Heart Failure Registry. It's the lack of guideline-dependent medical treatment in patients with heart failure with reduced ejection fraction, and frequent readmissions, they were associated with a very high 5-year mortality. Only 25% patients were discharged from index hospitalization on optimal medical therapy, and prescription of optimal medical therapy at discharge was associated with lower 5-year mortality in patients with heart failure with reduced ejection fraction. But yes, there is a caveat to this. The patients where you are not able to use the optimal dosage of drug, they are actually sicker patients, and they anyway are having a high morbidity and mortality. Interventions which are aimed at increasing the guideline directed medical therapy may improve heart failure outcomes in India. That's a wishful thinking. So our goals of treatment are increased survival, reduced morbidity, and decreased morbidity. People should feel better, the hospitalization should reduce, and the survival should improve. Well, as the if we see the past, then the landmark trials were happening once in 5 or 10 years. Now every year we get one landmark trial. That's because of the advancement in the science, and yes, it has definitely changed the uh, treatment and improved the morbidity and mortality in patients who are having heart failure. The drugs which have shown their benefit are beta blockers, mm, uh, mineralocorticoid receptor antagonists, then ACE inhibitors, ARBs, ivabradine, then uh, LVAD device, implantable defibrillator, and cardiac resynchronization therapy. And of late, we did have a landmark trial of ARNI. So paradigm heart failure, yes, it brought a paradigm shift in the treatment of heart failure. So this is an important trial. We all have undergone in details in various conferences about this trial. So I'll be discussing in brief about this trial. What were the patient populations who were studied? So ARNI was studied in patients who are having heart failure, NYHA class 2 to 4, and reduced ejection fraction. Reduced ejection fraction is EF less than 40%, and preserved ejection fraction is more than 50%. Between 40 to 50, it's a mid-range ejection fraction. Regarding mid-range, we'll be discussing the data later. So here the enalapril therapy, because that was a well-proven therapy among ACRBs in heart failure, that was compared with the ARNI. So it was guideline-based optimal medical therapy that was compared with ARNI, whether we can uh, do better than what the already existing medical therapies are doing. So inclusion and exclusion criteria, I think we all have gone through the whatever is the exclusion criteria for ACE or ARB. That is practically the exclusion for ARNI also. ARNI is having slightly more incidence of angioedema as compared to ARBs, and almost equal to ACE inhibitor or slightly less than ACE inhibitors. So apart from that, the exclusion criteria are practically same. What are contraindications to ACE or ARBs? They are the contraindications to ARNI also. So largest mortality morbidity trial in patients with heart failure with reduced ejection fraction. The trial was most geographically diverse trial in patients with heart failure with reduced ejection fraction. The India was also a part of this trial. It was most racially diverse heart failure trials. So there was significant reduction of CV death, heart failure, hospitalization, and overall mortality as compared to enalapril with ARNI. It also reduced sudden death. So the medical therapy for heart failure, the ACE inhibitor, ARB, beta blocker, mineralocorticoids, receptor antagonists, they are all class 1. And hydralazine nitrate was used in patients who were ACE or ARB, where it was contraindicated. So they all have proven their role in guideline directed medical therapy. The benefit which is shown with the ARNI, uh, that becomes important because this is over and above the benefit we have already achieved with ACE or ARP. So there was a significant improvement in NYHA class after ARNI. The ARNI was superior to ACE inhibitor across all the subgroups of chronic heart failure, irrespective of age, ejection fraction, EGFR, or baseline anti-proBNP or systolic blood pressure. So all the trial results are on the better side with a lesser hazard ratio as compared to enalapril with the ARNI. So there is an illusion of stability in heart failure. 20% of stable patients in paradigm heart failure, they had a primary event. 70% died during the course of the trial. Of stable patients who experienced a primary event, death preceded heart failure hospitalization in 50%. 60% of those deaths were sudden deaths. So if you want to prevent sudden death, then the best therapy is AICD, and ARNI also reduces sudden cardiac death. So that is definitely complementary to that. So all the patients who are having class 2 and above heart failure, they are going to benefit. So here we have to understand very clearly that asymptomatic LV dysfunction, that is one subset where their ARNI has no role as of today, as far as the guidelines and evidence-based medicine goes. So people can have, suppose a patient gets an MI, remains stable, and on follow-up, if you see the EF of 40% and patient is in NYHA class 1, that is a that is purely that is not a candidate for ARNI. So ARNI is to be given in patients who had heart failure and not asymptomatic LV dysfunction. So ARNI should be started as early as possible. We should not wait till deterioration happens. If we see the overall guidelines, then ARNI is indicated in NYHA class 2 and above, or patients who are in NYHA 1 but had a history of heart failure. So if there is no heart failure, or patient is having asymptomatic LV dysfunction, yes, their ARNI has no role as of now. So is acute decompensated heart failure different from de novo heart failure? Yes, there are some differences. If somebody is having a chronic LV dysfunction and presents with acute decompensation, that is acute decompensated chronic heart failure. If the first presentation is heart failure, then this can be a pre-existing illness, or it can be viral myocarditis, acute valvular regurgitation, or acute MI with heart failure. So the treatment is slightly different as far as a chronic LV dysfunction or acute LV dysfunction goes. So chronicity is established theoretically once 3 months have passed after heart failure. Many patients who are having viral myocarditis, they will actually improve within 3 months. Almost 50% of them improve in 3 months. So these are not the candidates to be considered for some therapies like AICD. If you see a patient who presents to you with heart failure, is having ejection fraction less than 30%, and you do a coronary angiogram, coronary angiography is normal, patient is having left bundle branch block, and you advise that patient a CRTD, no, that is not to be done. You must wait for 3 months stability of heart failure symptoms to call it a chronic heart failure, and then decision for AICD, CRTD, depending upon the QRS duration, is to be taken. And as far as medical therapy is concerned, that practically remains same for both de novo heart failure and acute decompensated chronic heart failure. And why this question has actually arisen in our mind, that if ARNI has shown their benefit in chronic heart failure, why shouldn't they be used in acute decompensated heart failure, just like ACE or ARBs? The reason is ARNI is having two actions. It's a combination of two drugs. One, ARB valsartan. And second is we are giving, if when the BNP levels are very, very high in acute decompensated heart failure, and there if you block the BNP degradation, then this may lead to acute renal failure. This was something which was considered whether ARNI are to be used in acute heart failure or not. That's why the first trial which was conceptualized was uh, in chronic stable heart failure patients. So in acute decompensated heart failure, as of now, we do not have a data where ARNI was starting right on the day one. Patients were stabilized on medical treatment. None was receiving IV diuretic. And of course, hypertension is a contraindication. None of the patient was on iron drops. So Pioneer HF was the trial design. The patients were stabilized in the hospital. Systolic blood pressure has to be more than 100 mmHg, and there should not be IV diuretics in prior 6 hours. So acute decompensation was actually stabilized, and then ARNI were given, because pro BNP can be in thousands, say 30,000, 50,000. We have seen the pro BNP in patients who are having acute decompensated heart failure. And there, if you block the degradation of BNP, there can be excessive vasodilatation and complications thereof. So as of now, those subsets are still contraindication for ARNI. So no IV vasodilator in prior 6 hours was used, and no IV inotropes in prior 24 hours. So patients were medically stabilized, and thereafter they were given ARNI versus enalapril. And here the mortality benefit was not seen, but the p-value was not significant as far as mortality is concerned. But yes, pro-BNP levels were more significantly reduced with ARNI, and symptomatic improvement was there. Plus, the risk of hospitalization was reduced in patients who were given ARNI as compared to enalapril. So as far as medical treatment goes, personally, I would consider de novo heart failure similarly to acute decompensated heart failure as far as medical treatment goes. It's only the definitive therapies like device therapies where we should be waiting for 3 months. As far as medical treatment is concerned, there is no need to wait for 3 months. You can just stabilize the patient, just like the previous trial where no IV inotropes are given and no IV diuretics are given. And if patient is stabilized on medical therapy, you can straight away go with the ARNI. So we have small data or large registry. So we have evidence where de novo heart failure was treated with ARNI. So similar to the previous Paramount data, the things were seen on the same trend. There is the composite endpoints were significantly reduced with ARNI therapy as compared to ACE inhibitor or ARBs. So all practically all same things are being told in different small studies or small registry data. So in transition study, the results, the early intervention with ARNI should be considered to delay the disease progression in patients with de novo heart failure. Similar to the previous trial where acute decompensated heart failure of acute decompensation of chronic heart failure was treated with ARNI versus enalapril, this absolutely similar results were seen. So if we see the 2021 update to the previous 2017 guidelines, then ARNI has got it is a preferred choice in foundation therapy along with beta blockers and mineralocorticoid receptor antagonist. Because of the new evidence, ARNI is now also recommended in newly diagnosed heart failure, and not only just stable heart failure, also unstable heart failure where patient is stabilized in short time pre-discharge. Clinicians should aim to achieve the optimal therapy within 3 to 6 months of initial diagnosis of heart failure. And the recent new kid in the block was SGLT2 inhibitor, which has shown benefit in patients of renal dysfunction, without renal dysfunction, heart failure with preserved ejection fraction, heart failure with reduced ejection fraction. That is something which new has come with recent guidelines and recent data. The ARNI may be considered as a first-line therapy instead of ACE inhibitor in heart failure with reduced ejection fraction in both stable patients and in unstable patients stabilized in hospital. So I won't go through these lines again and again. If patient is asymptomatic LV dysfunction, absolutely no need to shift. If patient is having a history of heart failure and patient is stable on ACE or ARB, they must be shifted to achieve the maximum possible benefit. And if patient is having inadequate relief with ACE or ARB, they again are to be shifted to ARNI. Then how to shift? If patient is on ARB, you can skip the dose of ARB and just shift to ARNI. There is absolutely no problem. If patient is on ACE inhibitor, then you have to have a washout period of 36 hours. Otherwise, risk of angioedema, which can be life-threatening and that can be very high. So that is a contraindication if somebody has received ramipril or enalapril 36 hours prior, they should not be given ARNI. What are the dosage equivalent? If the dose of enalapril is say less than 10 milligram per day, you can start with there you can start with the 50 milligram BD of ARNI, and if the dose is more than 10 milligram, there you can start with 100 milligram of ARNI a day. And escalation should not be done before 2 weeks, just like all antihypertensives or all vasodilators. Well, the most important reason for not achieving the target dose of ARNI is probably the disease process, because we are seeing patients in more advanced stage of heart failure, and we are considering ARNI not in patients who are stable on ACE or ARB and had a history of heart failure. We are actually using them as a last resort when ACE or ARB have stopped responding. Their disease has already progressed and patient many a times is having a lower blood pressure. So these are I personally believe is the most important reason for not achieving the target dose of ARNI. And that's why the effect is also suboptimal. So the patients who are stable on ACE or ARB but had a history of heart failure should be shifted to ARNI in time, and they are the patients where you should be able to achieve target dose very soon, within 3 months of initiation of therapy, and these are the patients who will benefit most. So if we don't, if we are, these are the reasons which are where we are not able to achieve the target dose, or we are not able to start the ARNI. Worsened EGFR, symptomatic hypotension, hyperkalemia, or GI symptoms. But most important, I think, is the reason is that we are considering ARNI very late. So even if we are not able to achieve the target dose, still the benefit is there. And these are the patients who are not able to achieve the target dose of ACE or ARB also. So when we compare apple to apple and orange to orange, yes, there is a clear-cut benefit with ARNI once we are comparing the reduced dose of ARNI versus reduced dose of ACE or ARB. The participants taking lower than target ARNI dosage, they had a lower risk of primary events compared with those taking the lower than target dosage of equivalent enalapril. Per se, this is the trial data also, and this is our personal experience also, that if patient is not having symptomatic postural hypotension, you can use ARNI in patients who are having a blood pressure of 100 to 110. Less than 100, it's a contraindication. Per se, I have never used ARNI in such patients, and that is the guideline directed therapy also. The risk of hypotension is not more as compared to enalapril once we are considering ARNI. It is same or less. Well, one, we need to correct the volume or salt depletion. Patient should not be over diurized. And if hyperkalemia is not an issue, then we should be using the lowest, the dose of mineralocorticoid receptor antagonist, that is 25 milligram of aldactone or eplerenone. And rest of the loop diuretics may be reduced. And we can reduce those vasodilators which do not have a mortality benefit and are having only morbidity benefit. So there, if we replace nitrates or calcium channel blockers with ARNI, we are achieving both morbidity and mortality benefit. Well, all the patients of EF less than 35%, they are not candidates for CRT. Only those patients who are having LBVV and EF less than 35% are indications for CRT. In patients who are NYHA 2 and above, in asymptomatic LV dysfunction, CRT is indicated in when EF is less than 30%. So the same is true for ICD. If symptomatic patient, then ICD is to be considered in EF less than 35% and in asymptomatic when EF less than 30%. So both are having their independent role. For sudden death prevention, ICD scores over ARNI, and for heart failure symptomatic reduction, the if patient is having LBVB, then ARNI and CRT probably are equal. And for patients who are not having LBVB, their ARNI is the choice. CRT you are not offering anyway. ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients who have recovered from a ventricular arrhythmia causing hemodynamic instability and who are expected to survive for more than 1 year with a good functional status. So that NYHA class has to be, if you are considering AICD, then you can consider in NYHA class 2 and 3. CRT can be considered in NYHA 4 also, but NYHA 4 is a contraindication for AICD because the patient is not likely to survive more than 1 year with good functional status. Yes, but all these are candidates for ARNI. Well, almost 30% of diabetics ultimately develop heart failure. And if you see a pool of heart failure patients, almost 30% have diabetes. So just like ACE or ARB, ARNI also reduced the need for insulin to a to a marginal extent. Of course, they cannot be used as anti-diabetics, but the need for insulin or escalation of dose of OHA is definitely decreased, just like ACE and ARB with ARNI also. ARNI is not to be used in asymptomatic LV dysfunction, but can be used in patients with symptomatic heart failure if EF is more. Uh, if we see the ARNI data in preserved ejection fraction, there the ARNI was beneficial up to EF of 57%. Though we are considering mid-range ejection fraction between 40 to 50. But if we see the data which we'll be discussing now, the ARNI was beneficial till the EF of 57%, and beyond 57%, ARNI didn't show any benefit. The prior failed trials outcome in heart failure with preserved ejection fraction of various vasodilators we have seen. The ARNI is slightly different. It did not reduce mortality, but it did reduce the hospitalization with heart failure in EF up to 57% when patients of heart failure with preserved EF was tried. In Paramount trial, the LA size was reduced and NT-proBNP was reduced. NYHA functional class was reduced. Mortality was not reduced, but heart failure hospitalizations, they were reduced. So symptomatic patients, yes, the ARNI has a role. Only patients who are not having any symptoms, or when symptoms are there plus EF is more than 57%, these places have not shown some significant benefit with ARNI. They are at par with other vasodilators. So you are having a good choice to use whatever you want. We have discussed, yes, I think we can, and our purpose is not only to reduce mortality, but also to reduce morbidity. And when we are reducing heart failure hospitalization, then that definitely is financially and personally beneficial to the patient, and it should be used. So new FDA indications open up with for use of sacubitril valsartan in heart failure with preserved ejection fraction. The contraindications for ACE inhibitor, ARBs, and ARNI are almost same. That is angioedema, hypotension, impaired renal functions, and hyperkalemia. The cuff with ARNI is less than anadepril, but more than ARBs. And so is angioedema. If we see the hyperkalemia in mild renal dysfunction, it is more with the ACE inhibitor as compared to ARNI. So ARNI can be tried, or maybe ARNI may be combined with the patient with loop diuretics, and you may stop mineralocorticoid receptor antagonist. Anyway, they have to be stopped in patients with renal dysfunction who are having hyperkalemia. So you can try ARNI with the diuretics in patients who are having hyperkalemia. So they are more beneficial as compared to ACE inhibitors. And if still there is hyperkalemia, then you have to stop the drug if potassium is more than 5.5. So what are the contraindications and cautions? Just to revise, a use of ACE inhibitor in last 36 hours, history of angioedema with ACE inhibitor or with ARNI or ARB, pregnancy, lactation, severe hepatic impairment, concomitant aliskiren use in patients with diabetes, known hypersensitivity to either ARB or ARNI. Then cautions are mild to moderate renal dysfunction. There is the starting dose remains same. Thereafter, we have to monitor with the further renal functions and serum potassium. If this renal impairment is severe, there is no much data. You can start with the reduced dosage if there is no hyperkalemia, but otherwise there is no large data in patients who are having significant renal impairment. In mild hepatic impairment, the drug can be used, and in moderate hepatic impairment, one can try the reduced dosage, but in severe hepatic dysfunction, the drug is contraindicated. Just like ACE-ARB, it's contraindicated with renal artery stenosis, hypotension, and volume depleted state. Drug interactions we have discussed with ACE inhibitor and aliskiren and potassium sparing diuretics. NSAIDs, they may lead to increased risk of renal impairment. Lithium, it increases risk of lithium toxicity. If somebody is having MDP and is on lithium, there, yes, we need to monitor the lithium levels. Well, it's difficult to tell the exact percentage, but almost 15 to 20% patients, yes, there will be contraindications to use ARNI. For hyperkalemia, the low potassium diet, the high potassium is there in banana, citrus fruits, and coconut water. These three things are to be avoided. Small dose of loop diuretics can be added, and MRAs can be stopped. You can use K-bind sachet with all three major meals. That should also prevent the potassium rise. And if patient requires admission, then one has to start with glucose insulin infusion in stubborn cases, and one has to stop ARNI. ARNI, we people are discontinuing only if there is a contraindication. So the disease has progressed, or there is a contraindication, or patient develops some complications with ARNI. So yes, these patients will have a dismal prognosis, and it is not just because of it's the disease process which is severe, and that's why it is having a higher mortality. So this actually is a not easy subset to define. If somebody is having LV dysfunction and has improved and was having a chronic substrate for LV dysfunction and now has improved with treatment, should continue treatment lifelong. But the de novo heart failure or the viral myocarditis, which recovers after 3 months, there I'm not sure, and we do not have actually data, and nobody will be able to answer that question. There, one has to clinically assess the patient with reduced dosage, and one has to follow. But patients who are having a chronic heart failure condition had acute decompensation, and now on treatment they have stabilized and their EF has improved. Those patients should receive the guideline directed medical therapy lifelong. So the ARNI is a molecule of century and it is indispensable. It is superior to ACE inhibitors in reducing CV death, death, heart failure hospitalization, and sudden cardiac death in patients with heart failure with reduced ejection fraction who were having NYHA class 2 and above, or an NYHA class 1 but are having a history of heart failure. ARNI also improves the LVEF in heart failure with reduced ejection fraction and reverses the adverse LV remodeling and improves quality of life in both heart failure with reduced ejection fraction and preserved ejection fraction. ARNI should be initiated as early as possible in patients with acute heart failure and in de novo heart failure, acute decompensated heart failure and de novo heart failure. Here, time is life years. Patient should be stabilized, should not be on IV inotropes or IV diuretics, and after stabilization, we should start ARNI as early as possible. ARNI should be given for at least 3 to 6 months along with other foundational therapies of heart failure, and EF should be reassessed with echo and or MRI before the patient is considered for ICD or CRT. ARNI should be used in all patients with heart failure with preserved ejection fraction up to LVEF of 57%, along with SGLT2 inhibitors to reduce heart failure, hospitalization, and improve quality of life. Thank you.